I confirm, Lord, we have had insight to, and we've also had an opportunity to consult with Dr. Bunker prior to the board commencing today.
Okay. Thank you, Mr. Porter. We might proceed. This will be admitted in evidence as triple G.
Dr. Butler, there's the evidence, if I can ask you to turn to page 48 to 50, which contains your condensed C. There's an indication from my little colleague mistake that your C is not placed in issue, so I'm just going to briefly lead you on that. You corrected in 1988 you obtained the degree MBCA degree from the University of Pretoria.
Cape Town.
It says on your CV Pretoria.
Oh, that's a typographical error on the part of my secretary. I apologize. It's the University of Cape Town.
It's a significant error.
And then in 1995, you qualified as a neurologist. Is that correct?
That is correct.
And in 1998, you also successfully wrote the Canadian Society of Clinical Physiology EEG exam.
Yes, I spent, following my graduation as a neurologist, I went to Canada where I worked as a fellow in an epilepsy unit, where I did epileptology for 2 years. And at the end of that 2-year period, I wrote the Canadian examinations.
If I can ask you, page 48, just to briefly take a walk through your relevant related work experience and current position.
I don't have a copy of it, but I'm happy to just enunciate it from memory.
And I'll just give you a copy.
Upon my return to South Africa in 1998, in the middle of 1998, I was appointed as a consultant at the University of Stellenbosch and worked at the Tygerberg Hospital. I subsequently became when I moved into private practice, I subsequently became a part-time member of staff, and I remain a member of the university, a part-time member of staff at the University of Stellenbosch, and I'm also a part-time consultant for the University of Cape Town. I started a private practice in 1990, and that's at Constantiaberg Hospital. The practice consists exclusively of seeing people who have various forms of seizures, so I subspecialized in that area, as should be self-evident from my subsequent training. So I investigate people who have various forms of seizures and blackouts.
And I see that on page 48 at the bottom there, you also ran a weekly epilepsy clinic at Tyne Hospital, in which neurologists and registrars consulted you on all cases in the clinic.
Yes, I did that until the earlier part of this year. That has been subsequently discontinued, but I still provide consultancy services to the department there. And we have a video link. We do a Friday academic meeting at our hospital where we discuss largely epilepsy patients. The our meeting from 8 to 9 on a Friday morning has a video link to both the University of Cape Town and the University of Stellenbosch neurology departments, so that their members of staff and trainees can listen to our presentations.
And then the weekly 1-hour EEG teaching session, is that still ongoing?
So yes, as part of the video link, I will be commencing shortly so that has been ongoing because I'm no longer going there on a Tuesday. Hopefully very shortly, no later than early next year, I'll be able to continue that using our video link.
And then you said at the bottom that there's a weekly evidence-based neurology journal which is based on skills that you acquired during your 2-year formal training in the field of evidence-based medicine at the University of Western Ontario, Canada, between 1996 and 1998.
Yes, that's correct. So the evidence-based medicine journal club that I ran, again, when I discontinued, so that was, we ran that weekly for the better part of 18 or probably 19 years. And just because of time pressures, I no longer go there, as I said, on a Tuesday, so we've stopped that.
And then lastly, you still lecture undergraduate medical students?
Yes, so I give the annual lectures to the University of Stellenbosch medical students on epilepsy.
Then you confirm the remainder, going back in time, part of your CV of indicating relevant related work experience and positions dating or spanning the period December 1989 to July 1996, as set out on page 49.
Correct. Then
under paragraph 6, you also makes mentions of peer-reviewed publications. Perhaps a few that you can just highlight, dealing specifically with epilepsy.
Yes, unfortunately the list is incomplete again, just I haven't updated this for a long while, but we've published several articles in the last couple of years. You will notice that number 5, for instance, Begley et al. I served on the International League Against Epilepsy Economics Commission, and where we looked into health economics in the field of epilepsy in different countries. There were a panel of, I think, 6 or 8 of us, and the proceedings of that were published in a scientific journal, as you can see, in Epilepsia, which is the preeminent epilepsy journal. And we've published other articles since then, including we have a research unit at Constantiaberg Hospital, and my research assistant, Dr. Ayaz Delapuri, is particularly skilled at functional MRI. So we have published in that area, listed there, and some more recent publications. In fact, 2 are in the process of being published. So as I said, that list is incomplete, I'm afraid.
Then, Doctor, under paragraph 8, page 49, going up to page 50, it's great you then list there the recent conference presentations that you, international presentations, by the looks of it, biological between 2013 and 2016, which you attended.
Yes.
Which you gave to the lectures.
Yes, I have presented at some of those, yes.
You then confirm the correctness, although you say it's slightly outdated, of your... Yes. Doctor, can I then ask you to go to page 1 of Exhibit Triple G. This is the report. I just want you to take His Lordship and then assess it through. I will from time to time just ask questions if we need to elucidate on some of this aspect, where you can just take us through your report, please.
Yes, so prior to my involvement with Mr. van Breda, I confirm that I have been consulted about and seen Henri van Breda on several occasions. As has already been mentioned, I've consulted both with yourself and with Advocate Galloway, both prior to and since the compilation of this report.
And it's also great that you've also consulted with Advocate Galloway prior to you seeing my client, which we'll refer to in recent weeks.
Correct.
Then, under paragraph 2, Doctor, you make mention of documentation that was made available to you at the time of formulation of this report. There's this one corrigenda, as you indicated, page 26 of the Triple G. Apart from the documents mentioned there, you also had sight of the pre-explanation of the accused that day.
Correct.
Most of it has been annexed here too, and there will also be reference to 2 video clips which will ask to be admitted into evidence when we get to that part of the evidence.
Yes.
You can confirm paragraph 3.1 to 3.6 of Exhibit Triple G. Those are documents relevant to your report.
Indeed.
Right. Then from paragraph 4 onwards, you explain the chronological sequence of events. And I just want you to explain the tactical lordship and the necessity to what had happened, how it came about that you are being called today as a witness.
So I've listed the events in chronological order here because they're relevant in terms of the diagnosis and the implications thereof for Mr. Van Breda. So I was the ward in which I work, which is C ward at Constantiaberg Hospital, was in fact contacted prior to the first telephone call that I received about him. And the call that the ward received was on 8 November 2017. It was a Wednesday evening or late afternoon. I do a late afternoon, early evening ward round. And the sister mentioned to me that she'd received 2 calls, and she gave me a piece of paper with their numbers on. One was from the girlfriend of Mr. Van Breda, and the other was from his girlfriend's father, who, as it subsequently transpired, turns out to be a general practitioner. I completed my ward round on the particular evening. I have, at the end of every day, somewhere between 12 and 25 calls to return, and so because this was not high priority in the sequence of, as I identified on the list of people to call, I didn't call them that evening. The following morning, shortly after my arrival at work, I received a telephone call from the father of Mr. Van Breda's girlfriend, Dr. Daniel Janssen van Rensburg, who is a general practitioner and who I do not know and have had no previous contact with. He telephoned me and indicated that Mr. Van Breda had what he called a seizure, and he requested that I should see Mr. Van Breda, which I agreed to do, since this is in my field of expertise. He gave me no other medical details, and as you will see in paragraph 6, given the historical context, I silently considered a differential diagnosis. And I should probably pause at this point and just explain to you that the diagnostic process in medicine, in an evidence-based way, begins the moment, in fact, begins before someone walks through your door. So if someone says to you, if someone arrives in the emergency unit at a hospital complaining of chest pain, there are already probabilities, what we would call pre-test probabilities, of them having certain conditions. So the prevalence might change in different settings, but the probability, those probabilities exist, and so when you receive a phone call of this nature, you immediately, in your own mind, sometimes quite intuitively, construct a list of probabilities. So to give you some idea of, in my practice, and I've seen over 20,000 people with various forms of seizures, in order of probability, a high percentage of the order of 70 to 80% would have epilepsy. A much smaller percentage would have maybe 15 or 20% would have non-epileptic, what are called psychogenic non-epileptic seizures, which is one of the differential diagnoses. And then there'll be other less common ones such as syncope, which is where you lose consciousness because of a loss of blood to the brain, transient loss of consciousness. But given the media attention in this case and my prior knowledge, I had to instinctively consider the possibility of malingering. You will see there that I've listed in order of priority, or in order of likelihood, my instinctive order of likelihood of probabilities are different to the prevalence of the population that I see. And this is unquestionably, on reflection, has been influenced by my pre-existing biases, which no doubt were partially, if not substantially, influenced by media attention that this case has received. So I should also, at this point, and just to be completely transparent about my biases, those of us who work in evidence-based medicine, we are particularly interested in bias and the way it permeates the scientific process, because we have to make due allowance for it, and it permeates every sphere of the scientific process. And of course, us being human beings, each of us carry our own biases. So evidence-based medicine tries to attempt to deal with these biases in an explicit manner, so that when you arrive at conclusions, they are valid, and you can make due allowance for the biases that exist. So my biases, I have to disclose these, were strongly against Mr. van Breda. And this is, I think, of relevance because, as you will no doubt see in this case, the scientific evidence, in fact, strongly contradicted my pre-existing biases. So hence, in constructing that differential diagnosis there, in order of priority, I first considered psychogenic non-epileptic seizures as the most likely. I'll explain that to you. That is different from the second most likely, which was malingering, and then the third possibility, which was an epileptic seizure. So I think it's important at this point also, in discussing biases, just to confess or tell the court that...
We don't have to confess here.
Well, discuss my other biases or potential biases, and of course, money is an important issue in the process. So I have been very clear to both parties, firstly, that I'm on nobody's side, and secondly, that I have not, and I do not wish to, receive any financial remuneration for this process. I've obviously consulted with Mr. van Breda. His medical aid paid me for that, and that's you can come to your own conclusions, and you can come to your own conclusions at the end of this process whether whether bias has influenced me, or I've been biased in my conclusions. But what I'd like to do is take you through the scientific evidence and allow you to come to your own conclusions about about his medical condition and what transpired on the night of the murder of his family. So in discussing 6.1 and 6.2, psychogenic non-epileptic seizures is, as I said earlier, different to malingering. And people instinctively, when they hear the term psychogenic, think that this is faked or malingered or put on. It should be self-evident that I've distinguished these two for good reason. So just to be clear about the difference, firstly, malingering is the feigning of medical illness for secondary gain. And the secondary gain is important. So it's a deliberate, conscious, explicit attempt by the individual to feign medical illness, to fabricate a medical illness, and then there is either financial or other incentive for them to do, their secondary gain. So it might be to stay out of jail, it might be so that you can get a disability grant, it might be for an insurance claim, etc. So that's malingering, which is different from what are called psychogenic non-epileptic seizures. And these are seizures where people, and it represents part of a spectrum of conditions called the conversion disorders. And the way it works as follows, is that people can develop seizures, or they can develop other neurological symptoms like paralysis or loss of vision or memory loss, and we'll come to that later on, which is related to previous psychologically traumatic, emotionally traumatic events. And the way it works is as follows. The individual, having experienced emotional traumas, those memories are embedded in the memory and emotional parts of the brain, and the brain involuntarily, subconsciously converts the symptoms, the emotional traumas or emotional conflicts into seizures or other neurological symptoms. So this is a subconscious process. And just to make the point abundantly clear, the epidemiological evidence, and certainly our experience is exactly the same as the world's experience, is that the vast majority of people who develop non-epileptic seizures are young girls. So typically in the second half of the first decade, the youngest I've ever seen is about 6 or 7 years, but the majority of people are 80–90% in various series from other parts in the world are girls. They're typically in the teenage years, and there is a high incidence of various forms of abuse, either physical or sexual or of another nature. And so these young vulnerable brains, as it were, unable to cope with the emotional traumas that they've been subjected to, unable to articulate them, and in some times where memories are just, as it were, subconsciously buried, the brain automatically converts these emotional traumas into neurological symptoms, sometimes seizures. So the remarkable thing about them is they're not feigning medical illness. In fact, the striking thing is when I admit them to my ward and investigate them, they typically have their seizures very quickly. So there's no attempt at concealment, no attempt at trying to fool the doctor or the neurologist. The symptoms are there, they're real, but the brain is converting these emotionally traumatic events or conflicts into seizures. So in considering this differential diagnosis, I was mindful of the fact that he was going through a court case that is emotionally, must be, for anybody, very traumatic. So that had to be considered in the differential diagnosis. It's very common. I've seen hundreds of patients with this condition. And if you take people who go to epilepsy clinics across the world, somewhere between 10 and 20% of people who have a diagnosis of epilepsy, when they investigate it in the manner that I'm going to tell you in a moment, turn out subsequently not to have epilepsy, but to have non-epileptic seizures. So that's why I said after epilepsy, it's the next most common condition when people present with seizures. So, having very quickly in my own mind constructed that differential diagnosis, it became apparent that we had to embark on a scientifically rigorous process, as we do, as you will see, of coming to an unambiguous diagnosis. Given my pre-existing professional commitments on the Thursday in question when Dr. Janse van Rensburg called me, I immediately arranged for a 20-minute outpatient, or roughly 20-minute outpatient EEG recording, which was subsequently done by one of our technologists. And as you will see in the latter part of part of page 3, paragraph 7, I subsequently analyzed the EEG late in the afternoon, reported on it sometime late in the afternoon, and just to make the point, as I've stated there, the EEG was entirely normal.
Doctor, if you can just put into post, and I'll ask you to turn to page 47 with triple G. And there's also a slide on the television screen.
In fact, slide 37 would be perhaps most appropriate.
37.
So this particular slide is not in fact taken from that 20-minute recording. This is taken from the subsequent EEG recordings, but it illustrates what was seen on that 20-minute recording performed on the Thursday afternoon. And you will see that this was normal. So, and the slide in front of you is normal. You'll see in on the image that appears on the screen, that is a 10-second page. So from left to right is 10 seconds. And each of those solid vertical lines represents 1 second. Oh, I could probably do it from here, actually. Oh, I see, yes.
It would appear on like almost on the 3-second position. There appears to be what I suppose from a layperson's view would be termed from the spike.
Well, no, that's perfectly normal. So, so at this point, each of these channels here represents an electrical potential difference between two electrodes put on the head. So it's a potential difference, and each one of these channels then represents a different part of the head, as it were, and hence a different part of the brain. So and because cortical potentials, electrical potentials, are very low in amplitude, the recording itself is prone to extraneous artifacts, most notably the muscles that overlie or are somewhere between the brain and the electrode. So when you swallow slightly or you contract your muscles, a vast amount of electrical potentials from the muscles appear on the screen. So here's there's a little bit of muscle potentials there, and this big wave here is in fact an eye movement. So the eye has an electrical potential, and at the front of the eye it is electropositive, and the back of the eye it's electronegative. So when the eye moves, we can see it very clearly, and we can deduce which direction it's moving on the EEG. So this is because the eye is positive, the eye here, he's closing his eye at this point, and you'll notice just beyond that, there are these rhythms at the back of the brain that we call alpha rhythms, which are the normal brain rhythms that all of us have when we close our eyes. So this is representative of the EEG done on that Thursday afternoon.
So it's perfectly normal.
Perfectly normal EEG.
Right. Continue on page 3 and paragraph 8.
So it was, and perhaps at this point we should just pause and just, no problem. We should just pause and just explain why the subsequent tests were done. And important, again, from an evidence-based point of view, is to point out that every test has a certain diagnostic usefulness or utility. In fact, not only every test, but every symptom or sign or diagnostic test is subject to the same principles. And in fact, these are simply data points. Many people have a misplaced belief that a test is the only way to arrive at a diagnosis. And in some instances, a symptom might be more powerfully predictive of a certain disease than a sign or a test. And sometimes the sign might be more predictive than a symptom or a test. And sometimes the test is more predictive. So, so one has to understand the limitations of what you're doing. So the EEG test is what we call poorly sensitive, but highly specific. The poor sensitivity means that if you take 100 people with, the sensitivity refers to the ability of the test to find abnormalities when they're present, right? And so if a test has a poor sensitivity, as the EEG does, then if you take 100 people who have epilepsy and you do the test on them, only something like 20 or 25 in 100 will you find abnormalities, right? However, the test has a high specificity, which means that when you find abnormalities, then you can be very sure that the person has the condition. So it's useful if a test is a high specificity, it's useful then in excluding false positives. But when it has a poor sensitivity as the EEG, well, then you've got to do more tests, which is why I went on to do further tests on him.
So I was about to ask you, because paragraph 8, you alluded to the fact that despite the fact that the EEG was normal on the Thursday, you then arranged for Mr. van Breda, you admitted to hospital on a bed at the time.
Yes.
Was that decision made by you?
Correct, yeah. So because the test is not useful given it's negative, it would have been used. The reason I did it is if it was positive, then you have an answer. If it's negative, you don't have an answer. You're no further in the diagnostic process. So when it's negative, the test is useless. It's only useful when the test is positive. So because the test has effectively turned out to be useless, I then had to arrange for longer EEGs. And the only way of doing that, to do it over a 24-hour period, was to admit him to hospital and to run the EEGs. So that was arranged, as you will see in paragraph 8. On the Friday morning in question, I asked my secretary to phone Dr. Janse van Rensburg and to arrange for Mr. van Breda to be admitted to hospital to consult with me so that I could, A, get a history, and that's very important when it comes to the diagnosis of seizures, and then also for these 24-hour EEG recordings. So I could accomplish these two critical parts of the diagnostic process in one. I could see him, and I could simultaneously get moving with the testing. So he was admitted to hospital. The admissions take place just after midday. I'm not sure exactly at what time he would have come into hospital, but it would be just sometime after midday. The technologist applied the electrodes, and we then commenced the scientific process of recording his brain's electrical activity continuously for 24-hour periods, and at the same time we have simultaneous video recordings that continue. We run heart monitors, ECG. You'll see on the bottom trace of the screen here that you will recognize as the ECG, and that's why it beats regularly like that. So the heart is monitored at the same time, and we have a microphone. And this allows us, this process has multiple advantages, and notably, firstly, the abnormalities that I referred to earlier, the spikes, what we call spikes, or they also called interictal epileptiform discharges, is the other name for them. When they appear on an EEG, then you can be, then that is very strongly predictive of the presence of epilepsy, independently. So you can then also record events, and you can record clinically typical seizures or blackouts or whatever the patient has, or other symptoms. And as you will hear later on, seizures do not always, and quite often, in many people, patients have seizures that are minor, and these are not recognized widely as being seizures. And when patients have symptoms such as they feel feeling of arising, feeling out of their stomach, for instance, and déjà vu simultaneously, when they report that symptom, they push a trigger button. It puts a mark on the EEG to the millisecond that they push it. We've got a video camera. We can see exactly what they look like. We can hear them talking, and we've got the cortical correlate of what's going on. We can see whether that's a seizure or not. So,
that's the reason for the continuous monitoring.
Correct. And not in his case, but for instance, we investigate many patients who have established epilepsy, who continue to have seizures. So I personally have investigated and read the EEGs of over 3,500 people who've come into our hospital over the years. The majority of them we investigate with a view to epilepsy surgery, where medications have failed and they continue to have seizures. And then we go through an elaborate process of working out exactly what's going on in the brain, where the seizures are starting. We work out, sometimes we have to implant, in quite a lot of patients, we have to implant electrodes in and around the brain to precisely localize the region of seizure onset. We've got to work out where normal cortical function is, and in those patients we then operate on them to remove the region where the seizure starts. I say that because it's relevant later on. The majority of people have what are called focal epilepsies, and focal epilepsies are epilepsies that start in one part of the brain. They're the ones we operate on. You can see the process has to be very scientific and accurate for us to be able to do that and take out bits of their cortex to produce a seizure-free state. That is different to patients who have what are called generalized epilepsies, which appear where the discharge appears simultaneously, or as we call it, synchronously throughout the brain. And that's the standard international classification. Medical students are taught this from an early stage of their careers, that the epilepsies in general, you can subdivide, and I'll come back to this later, into those that are focal, we call focal because it starts in one area, and those that are generalized where it's all over. So he was admitted for those reasons. In his case, for a diagnosis, but many patients we investigate are investigated for surgery.
You consult with him that Friday afternoon between 5 o'clock and 7 o'clock, is that correct?
Yes, I can't say exactly when that's typically when I do my afternoon ward round.
In paragraph 9, you list the history that you obtained from him and his girlfriend who was present in the consultation. Can you just take us through that?
Yes. So the okay, very good question. Because of the diagnosis of seizures, as you'll hear, is a systematic process where, because patients frequently lose consciousness, and in the period in which they lose consciousness, they are not, as it were, with it, we need what we call in medicine collateral history. So there may be symptoms which precede the loss of consciousness, and those symptoms that precede the loss of consciousness, the person, him or herself, will experience and be able to report. From the moment that they lose consciousness, and seizures, those symptoms are then indicative of focal seizures for some people. The moment they lose consciousness, we have no independent account of what's happened to them during the seizure. So it's almost mandatory wherever possible to have what we call collateral history of what transpired when you blacked out. So the surrogate for a video camera for a seizure outside is another human being. They're the best surrogate we can have for video. And that's why if I see people who come to the consultation alone, the first thing I have to do is pick up the phone and phone other people around and try and find out exactly what was observed, and then get as many people to either well, if they come to a consultation, to the next consultation, so that I can consult.
I can understand that in general terms. Collateral information is sought.
Yes.
But in this instance,
Oh, I see.
assuming there was malignity,
Yeah.
wouldn't the girlfriend be propping up the malignity? I'm not saying that.
Unquestionably collusion can occur, but we, in taking histories from everybody, we typically get as many people in. I mean, that's the rule in neurology.
And then paragraph 9, you obtain the following history. Can you just take us through that?
The history taking is, one can generally subdivide it into two parts. The one is then obtaining the spontaneous history from the person, and then what's sometimes called systematic inquiry or systematic interrogation, where you ask them specific questions. And they're both useful. They in an evidence-based way, one, as you will see, one has to be careful about how you go through this process. So the spontaneous history is generally obtained first. So just to give you his history, this is the history that he provided to me. He's 23 years old, he's right-handed, and in asking him about other clinically important medical illnesses, he mentioned that he'd had appendicitis at the age of 9 years. He also then mentioned that he used... Oh yes, sorry, I beg your pardon, yeah. Actually, I would have to just consult my notes, but I think almost certainly it was removed. I stand under correction, but I think that's correct. I probably assumed as much, Your Honour. You'll see then in 9 point... No, I understand. Yeah. Actually, it's a very interesting evidence-based issue aside, which is for years that, you know, appendices have been removed, but the evidence concerning this is changing. I'm not an expert in this field. I'm interested in evidence-based medicine. So whenever existing treatments and things are challenged by new evidence, then I'm always interested in, and there's emerging evidence that challenges the long-held belief that everybody with appendicitis needed to have their appendix removed. So that's my sort of minor interest in the subject. Yeah, quite right. So he also reported that he currently uses fluoxetine, or the trade name is Newsac, 40 milligrams daily, which is an antidepressant. It's called an SSRI, which is a selective serotonin reuptake inhibitor. That's just how it works in the brain, so that it gives you more serotonin in the synaptic cleft, which is the cleft between one neuron and the next, where the one brain cell, as it were, talks to the other. So that's how the SSRIs work. And he told me that he'd used this treatment since February 2015, and that he was prescribed this medication for anxiety and depression. He also reported the treatment being effective, an important question. So if you're going to take a treatment, it's got to work, otherwise you can hardly justify its use. And he reported no side effects, which sometimes, quite often, also needs to lead to the discontinuation of a treatment. He also told me that he had been prescribed a sleeping tablet in February 2015, but because this had produced daytime somnolence, which means it made him sleepy in the day, he'd stopped it because clearly this is an unacceptable side effect. 9.4, you'll see that there was no family history of seizures or febrile seizures, which sometimes can relate to the subsequent development of one of the forms of epilepsy, or as we call them, the epilepsies. He had no febrile seizures in his early childhood that he knew of, and relevant to any potential diagnosis of epilepsy, he'd had no previous injuries to the brain in the form of trauma, head injuries, or encephalitis, where you get a severe viral infection in the brain, or meningitis, where you get a bacterial infection in and around the brain. And these can scar or damage the brain and leave you with a long-term propensity to have epileptic seizures. He also then, he gave no other medical history of note relevant to his problem. So then I asked him to tell me what had happened to describe the events that had happened on the Wednesday afternoon that resulted in the consultation with me. So he reported that at about 1600 hours 30 on the Wednesday afternoon, 10 November 2017, he was sitting on his bed with his girlfriend, and he was very stressed, and he was discussing the court case. And abruptly and without any warning whatsoever, he became what we would call amnestic, which means he lost his memory. And
sorry to interrupt you. 10th of November is Wednesday. Actually, it must be the 8th of November. I think it was the Friday when you saw it.
I beg your pardon. That's correct. That's a typographical error. Yeah. That's it. I beg your pardon. So on 9.6.
9.6, Lord, the Wednesday was the accused reported of that he had seizure the 8th of the day.
Yeah.
The Friday when you saw it.
Yeah. So 9.6, at about 1600 hours 30, it should read on Wednesday, 8th November. 8th of November. So it was Wednesday afternoon. I remember it vividly. His account of events. And as I said, he was talking to his girlfriend, or reports that he was talking to his girlfriend, and he abruptly lost his memory. This is where the collateral history is important. So there's our surrogate for a video camera in the room is his girlfriend. And she reports that he suddenly looked like he was about to cough. He leant forwards, and then he fell backwards on his bed. And she spontaneously said that his eyes rolled back, as she put it, and his body and arms were shaking, as she put it, for approximately 1 minute. Now, 1 minute you must always take with a little bit of a pinch of salt, because these are people's best estimates at the time of what for them is an emotionally traumatic event. Many family members or friends who observe someone having an epileptic seizure frequently think that they die. And one of the challenges in managing patients and their families with seizures is in fact to just allay all these anxieties. So the point about all of that is when you're emotionally traumatized, keeping track of time, it could have been a minute, it could have been 30 seconds, it might have been 3 minutes. Scientific study of this, in fact, is quite interesting, is when videos of seizures are shown to doctors, and they are then subsequently asked to quantify the duration of the event, because they themselves are mildly traumatized by what goes on. They, virtually without exception, tend to overestimate the duration of seizures, as it is obviously objectively quantifiable. She also then said that his face was red and his jaw was clenched. He didn't turn his head to either side, and that's relevant because, and we'll come to this later, is that, as I said to you earlier, there are two types of epilepsies. There are those that start in one part of the brain, and there are those that start throughout the brain. And those that start in one side of the brain, sometimes in these big seizures, quite often produce an asymmetry of movement. So the other side, the movement on the other side will be greater, and the head will turn to one side.
So if the further seizure starts on the left-hand side, for example, on the opposite side, what you expect?
The head or the shaking might be more on the one side, or the head might turn to that side. The head, often if it starts on the other side, the head will in fact turn to the one side just in advance of the shaking. So it will just precede it.
You continue saying it was reported he didn't salivate?
So he didn't salivate, which sometimes happens in seizures. She said that his breathing was very noisy. When he regained his memory, he felt lightheaded, very tired and disorientated. So we'll come back to this later on, but these feelings that are reported by his girlfriend are the typical symptoms that people have after a major seizure. And that is, when the seizure is over, the dysfunction in the brain doesn't stop. And we'll discuss this later on, but this is referred to as the post-ictal period. And in the post-ictal period, the brain typically takes often several hours. Occasionally patients recover relatively rapidly, and sometimes it takes days after a seizure for the brain to recover fully. We'll get back to that issue later on. I then asked him whether he had lacerated his tongue, in other words, bitten his tongue, whether he'd wet his pants, in other words, whether there was incontinence of urine, or whether there was any aching of his muscles. They both said that none of those were present. These, just to make the point, are sometimes present during or after seizures, but not invariably. His girlfriend then told me that he appeared disorientated and that he looked like a drunk person. She then telephoned her father, who suggested that he take a medication called Zanor, which is a benzodiazepine. So it's a group of the family of drugs that are called the benzodiazepines. Valium is another one. And these medications, although they're widely known to be used for anxiety, in fact, they are very good medications for terminating seizures and for preventing seizures in the short term. So hence the advice from his girlfriend's father to take Zanor. He told me that he took this about 1,800 hours, which is about an hour and a half after he had this event, and he subsequently went to bed, fell asleep, he reports, at about 9 o'clock that night. He consumed no alcohol in the days preceding the event, and he'd gone to bed at about 2200 hours on the previous night and had woken about 700 hours on the day of the seizure. So then, having been confronted with this, the golden rule when we see patients with seizures is that, and this goes through my mind every time I see someone and anybody phones me about this, is the rule is the first seizure is commonly not the first seizure. So then you have to set about the process of establishing whether there's a history of these before, and very commonly there are. So I then asked him whether he'd ever had any similar events, and he and his girlfriend then told me that he had a similar event in approximately, and they couldn't be absolutely precise about this, February 2016. On the night in question, somewhere between 9 and 10, they estimate, while sitting outside on the pavement of a street and telling his story to his girlfriend. Again, I think it was, as I recall, related to the court case. He became emotional, and he subjectively felt emotional, should I say. And a short while later, and the interval's unclear, and without any warning, he again lost his memory. It was dark, and so when I asked his girlfriend about what did he look like, she said, well, it was dark, and she could see that he was shaking, but because it was dark, she couldn't see his face. And after a while, and again, as I said earlier, quantification of this exact time period is difficult, especially in retrospect now, a year and a half later. When it was over, she said that he appeared, to quote her, out of it and very tired. When I asked him how he felt after that episode, he said, I can't remember what I felt like. And that's not an uncommon report from patients during the post-ictal period. So the brain's not working well, cognitive function is not normal, and so people very often don't realize that something's wrong with cognitively and mentally. I then asked them specifically whether on the night in question, in February 2016, whether he'd bitten his tongue or whether he'd wet himself, and they both said no. I asked him again about alcohol use, and on that particular night he'd had 6 glasses of wine, somewhere between 5 and 9 that night, and his words were at least 6. And he, because presumably about 18 months had passed or a bit longer, he couldn't remember what his sleeping habits were the night before. He and his girlfriend mentioned, when I asked him, did they tell anyone about this? He said that, both of them said that they'd mentioned the event to friends, to quote them, who'd come over the next day, and his girlfriend reported the event to her father, and to quote him, he said, I said, well, what was made of the event? And his response was, we all thought it probably was just all the wine. So then, in attempting to inquire further about pre-existing seizures, I then set about, as I do for every patient who presents with seizures, a systematic inquiry about minor events that frequently, in fact, many patients don't recognize as representing epileptic seizures. And the systematic inquiry was then done, and of course this is relevant to the diagnosis of whether he has epilepsy, and then secondly whether he has what's called a focal form of epilepsy. Just to remind you, that type which starts in one part of the brain, or a generalized one which appears simultaneously or synchronously throughout the entire brain. And then the symptomatology tells you, if he has particular symptoms, tells you from which part of the brain it's likely to originate. So you'll know that the brain, for instance, is regionally specialized. So you have memory in your temporal lobes. So when you get seizures in the temporal lobe, you will evoke a memory from the past. And one of the hallmarks of seizures that are in the temporal lobes is because they involve the parts of the brain where memory is embedded, a seizure always produces the same symptom. So you get what's called stereotypy. So to give you an example of how specific those are, I'll give you two examples, in fact. When I was in Canada, I saw a patient who was in the garden on a Sunday morning, and he was doing his gardening. He was perfectly healthy, no problems before in his life, and he heard this little tune in his head. And it was the tune was a signature tune from a radio program called Gilmore's Requests. So he... So having heard this tune, it was a Sunday morning, he went inside and he said to his wife, what was on Gilmore's Request today? What music did they play? Because this is a signature tune and people could phone, I think they could phone in and request songs or something to that effect. And she looked at him and said, there's no Gilmore's Request today. It's Sunday, and the program's on a Saturday. So, so they both thought this a bit odd. It was a short little signature tune. And so subsequently he heard this again and again. It went on for, I forget whether it was a year or 3. And then after a couple of years, he had a major seizure. And so the diagnosis of these minor seizures was only apparent in due course. Because this memory was embedded there, the seizure, when it starts there, activates that memory. And only he, and not I, if I had an epileptic seizure in that part of the brain, I would not be able to have that symptom. It's individual specific. So that's the relevance of a history of these minor seizures. A, in establishing whether there's a pre-existing epilepsy, and B, to work out the symptom gives you a clue as to what goes on in the brain. And the symptoms the majority of them might indicate a focal form of epilepsy, and the only two symptoms of minor symptoms that might indicate a generalized form of epilepsy. So to reiterate, the majority of the symptoms indicate focal epilepsy, and most commonly, more people have focal epilepsies than have those that are generalized.
Okay, Dr. If you continue, Doctor, say that you also asked him whether he had any other blackouts, episodes of memory loss or loss of consciousness. Did he report anything about that?
So he simply said that he'd had a few episodes where his memory had become poor, but he clearly linked this to the excessive consumption of alcohol. Since, I think his words to me were, yes, while at college, he said. I think those are the words, yeah. Or since, I think they were in the last, I stand under correction.
These blackouts are part of growing up.
Yes, yes, yeah. So, I mean, many students are familiar with this sort of sequence of events, shall we say, and jollification.
Well, in paragraph 13, Dr. You said you then starting going, it appears from the list of questions of symptoms that you're looking for.
Yes.
Just take us to that.
Yeah. So there are a myriad of symptoms, and I run through this little checklist with patients. So of the many symptoms, just to make the point that only 2 of them indicate the generalized epilepsies, and all of the others are indicative of focal forms of epilepsy starting in different parts of the brain. So I went through these with him, and I'd asked him initially whether he had any, before I say this, perhaps I should say that the 2 symptoms, minor symptoms, that are indicative of generalized seizures are what are called petit moles or absences, so very brief staring episodes that typically last a few seconds without warning, a few seconds, and then you carry on, just like I've done, right? So that's a petit mole or an absence. And that is a generalized seizure. And then, so he denied the presence of that. I then asked him about the other type, which are called, medical term for it is myoclonus or myoclonic jerks. And in order to illustrate this to people, I usually just say, have you ever had any funny twitches or jerks? And then if they say no, I say like this, or like that.
You demonstrate now suddenly a jerk of the
Correct.
arms
Yeah.
or shoulders or something.
Yeah, and the reason I demonstrate it is precisely because people don't recognize those as minor seizures. Right? So, and when I asked him about any twitches or jerks, he reported intermittent, what he called shivers of his whole body, while completely awake and at any time of the day. He'd noticed some of these occurring just after eye closure, just falling asleep. And I think, as I'll discuss later on, one's got to draw the distinction between those that we all experience, or many of us experience, as you're drifting off to sleep, which is physiologically normal, and then the spontaneous occurrence of these jerks during overt wakefulness during the day, which is different. So that's called myoclonus. So of all the symptoms, and I'll tell you the others in a moment, of all the symptoms that I presented to him, the only one that he said that he experienced were these jerks. So I then ran through the checklist that I do, went through the symptoms of all the other ones, or all the other symptoms, should I say. And where are we now? So you'll see I ask questions like, do you ever see things that aren't there, hear things that aren't there, taste things that aren't there, smell things that aren't there, get frequent deja vu, out-of-body experiences, any strange experiential symptoms, funny dizzy episodes, panic attacks, etc., etc., brief nausea, which can be a seizure, or anything else that other symptoms that are strange but brief and episodic. And he emphatically denied all of these except panic, which he said that he'd experienced only on days when he was in court here, and when obviously very anxious. But he'd not experienced, and this is how one distinguishes, or is useful in distinguishing panic attacks from seizures. Seizures occur out of the blue. Panic attacks are frequently context dependent and provoked.